Start at 9. The meeting. Hello. Hello.
Hello, sir.
Yeah. So should I introduce a speaker or you will do that?
Sir, Akhilesh sir will give a welcome. Then
Right.
you can talk in brief about the speaker,
All right.
whatever you want to add on, sir.
All right. All right. Yeah. Okay. Yeah.
Good evening, Dr. Richa. I think you can try to share your screen. We'll start at 9 sharp. I think your this microphone is muted actually.
One moment, sir. I'll just share the screen.
Yes.
1 moment. So, is it visible?
Yes, yes. Could you make it full screen
Yes,
now?
sir. Yes, sir. Yes, I'm too. Is this fine, sir?
Yes, yes. Now it's full screen.
Okay.
We'll start at sharp 9, I think, sir. Matthew, sir, we can start at 9, right? Matthew, sir?
Yes, sir. Yes, sir. I am ready.
Okay, sir.
Hello,
We'll
sir.
start at sharp 9.
Most welcome, Dr. Richa.
Thank you, sir. So this will be because I talked to you, so I kept it on conventional implants only because otherwise topic would become very vast.
Sure, sure. That's enough. ഞാനിക്ക് കേൾക്കാൻ വയ്യല്ലേ അവർ പറയുന്നുണ്ടല്ലോ
Good evening, Mathew sir. Hi, Richa. Yashaswini here.
Hello, ma'am.
How are you?
I'm good, ma'am. Good.
Good. Looking forward to hearing from you.
I hope I'll be able to.
Do justice. Of course you will. Arey, shak hai kya?
Okay.
Right. Mathew sir, good evening.
Good evening, Yashaswini. Good evening.
Right. തുടങ്ങുന്നല്ലേ ഉള്ളൂ sir. We're just starting now.
Yeah.
Mm.
Dr. Akhilesh will start.
Yes, sir. Good evening, all. Welcome to the 7th webinar of AOMSIKerala. I request our Vice President of AOMSIKerala State, Dr. Srijit VP, to address the gathering, to welcome all the participants and our speaker. Srijit, sir.
Yeah, hi. Good evening, one and all.
Hi, Dr. Srijit.
Yeah, Mathew sir.
Yes, sir.
I welcome one and all for this 7th webinar. And topic about implantology. I welcome our speaker, Dr. Richa Angik. She is a well-known practitioner in implantology. Over to Mathew, sir, our moderator.
Our moderator for the day is Dr. Mathew Jose. He is the professor and HOD of Mogambique College of Dental Sciences, Kulashagaram. Sir, you can introduce the speaker and then ma'am can start with the topic. Sir. Over to you, Mathew, sir.
Right. Actually, I know about Richa. Just what is written here only. I don't know anything more about her. So I think if you have her CV, if somebody else better formally introduce in detail. But I know is written as Professor and Head Department of Dentistry at Bhagalpur.
Sir, would you mind, sir? Can I start? It will be easier.
Yeah, yes.
Sir, I did my BDS from Bapuji, 99 to 2004, Bapuji Dental College, Davangere.
Yeah.
And then I did my master's from Wardha, Sharad Pawar,
Right.
in maxillofacial surgery under Dr. Borle and Dr. Nitin Bhola.
Yeah.
And I'm doing maxillofacial. I was in our dental college here as professor, and I'm practicing both in Bihar and Jharkhand, doing maxillofacial surgery practice, sir, and definitely implantology, sir.
Right, most welcome. Actually, we are so glad.
In addition, she's also a fitness enthusiast. So she runs marathons.
Yes, I'm a full marathon runner and a Kathak dancer.
Yes.
Very good.
Super.
Thank you, ma'am.
Welcome.
Regarding the topic, I think regarding the topic, actually, it is a topic for the hour. It's a need of the hour. All maxillofacial surgery people entering in the field of arena of implants. Actually, in colleges, still it's with periodontists, prosthodontists, and maxillofacial surgeons. Some people work as a team in many colleges. In our college, we work as a team. Our team got all prosthodontists, periodontists, as well as maxillofacial people. So that depends on the colleges to colleges. Anyway, it is strictly mandatory for maxillofacial surgeons get trained in implantology. Nowadays, every clinic, it is done liberally. Liberally, implants are done, and people now coming with directly asking for implants. Previously, what it was the stage for bridge or crown. Now people just ask for implants, and so that if you're not competent enough to do implants, you will be thrown away from this practice field. So I think this talk will be highly beneficial to all of us. A big list of listeners are there, I can see. Hopefully, Dr. Richa will enlighten us with implantology. It is 1 hour is too short for us for this topic. We know that, but hopefully, Dr. Richa, you can enlighten us in this field.
Thank you so much, sir.
Yes, Dr. Richa, I think you can start the session.
Okay, sir. As we know, we suggested maxillofacial surgeons are doing implantology day in, day out. So implantology itself is a vast topic. And in this, there are conventional implants. Any patient entering would ask, would you do all on 4? Would you do all on 6? Would you do zygoma? Still not known to a lot of people. So in this topic, so I'll just deal with the conventional implants, because immediate implants itself is a different subtopic in implants, and 1 hour would be, I think, decently we'll be covering the important points in that sub. So the topic is empowering implant, immediate smile through implants. I'm Dr. Richa. I'll start the topic. Just 1 moment, sir. So all of us know what dental implant is. It is an alloplastic material which is inserted in the soft tissue in the bone. And once the osseointegration is done, this helps in the processes, in the aesthetics and the function for the patients. So I'll go to the topic straightforward. When a patient comes to our dental clinic, we do general physical examination. We take the medical history. Parafunctional habits, yes, a lot of patients are bruxers. A lot of patients have night teeth clenching habit. There are a lot of implants which have come up. which are considered to be very good in patient with bruxism. They can withstand the forces of mastication. But the absolute contraindication are the cases with acute infection, patients with chemotherapy, radiotherapy, which means they are in active treatment for malignancy, patient with myocardial infarction, or patient with cerebrovascular accidents or immunosuppressions. So once the patient comes, we analyze the patient. First, why was the extraction needed? And what are the repercussions of extraction in hard and soft tissue? We know as the extraction is done, the bone level decreases, the soft tissue loses its curvatures, and the beauty of the teeth is lost. So once we determine, was it cavity, was it periodontal condition, was it any trauma? So after you analyze the cause of the damage of the teeth or the loss of the teeth, then we determine the three-dimensional position of the implant. Where do we place? Because placement of implant will determine the final outcome of prosthesis. And we select what kind of implant is needed. That will deal with the active implant, passive implant, or the size and the length of the implant. So planning, we know planning of implant, it's X-ray. Clinical finding, once you have done the clinical analysis, you go for radiographic analysis, which has CBCT is very commonly used, which gives you the three-dimensional ideal position. Your half the work is done. With the advent of technology, they'll tell you exactly where to place the implants, where you have to protect the implants from the ideal, from the vital structures. And then the intermaxillary relationship, because the how will the tooth be positioned posteriorly in the occlusal area or anteriorly? How will be the emergence profile and the smile line? How will it come up? So basically, tripod guided concept, which is now coming with newer concepts like scanning, which I'll come later. And if there's a multiple missing teeth, so it's better for the beginners to go for the surgical guide, because there the chances of mistake is less, and the position will be ideal, and the prosthesis will be convenient, because finally prosthesis maybe is more complicated than placement of implants at times. So cases like the first X-ray we see, there are multiple missing teeth, and the bone is the bone loss is severe. Such cases we do not take for conventional immediate implants. We know this could be a case of all-on-4, this could be a case of zygoma or patient-specific implants. So we deal with patients who have simpler, or I would say that is bone loss is less, and placement of implant will be easier. So in that cases, we'll go for the immediate implant placement or the loading. So once the CBCT result has come, we would know the bone type, we know the trabecular pattern. D2, D3 bones are the ideal bone for the placement of implant. We're all aware about that. So once the CBCT is done, so if the first X-ray we see, immediate implants is definitely at times easier, because the extracted socket itself becomes a guideline for the positioning of our implants. And apart from that, the CBCT would tell you about the vital structure. We know about the looping of the mental of the nerve, that we have to avoid the implant placement nearer to the nerves and blood vessels. Similarly, if it is a full mouth case, in that, if we have root stumps or existing teeth is present, we can plan our extraction and placement of implant immediately. And this CBCT will become a very good guideline for us. Scanning, I would say, is the necessity of the hour, because scanning will, apart from this, because it's very, very frequently it's being used for in dental practice nowadays. So scanning will give you apart from the three-dimensional structure of the bone, the teeth, it will give us an idea of the biotype of the periodontium. It will give us the smile line. It will supposedly, if the biotype or the periodontium is thinner on the buccal side, we can place it bit more palatally so that our placement and the emergence profile of the teeth, which we make the processes finally, would look good in anterior teeth. So I think the videos are not playing. Just one moment. So scanning with it gives us a three-dimensional picture of the teeth. So in this case, we see there's a missing forceps. Once we scan, we know the adjacent areas, the space between the adjacent teeth, the buccolingual width, the mesodistal width, and the angulation of the teeth so that we can place our implant accordingly. Like in this case, we do not have proper position or proper space between the first premolar and the first molar. And then we have to decide how to place the implant further. So scanning pre-implant will determine in the placement, the implant occlusion, the natural aesthetics. It is a good occlusal marking point. It determines the pink and white ratio and bite recording. So once we have done the entire diagnosis part, clinical, radiographical, and scanning, we know the smile line. We need to know the tooth position, root position of the adjacent teeth, biotype of the periodontium, tooth shape, bony anatomy of the implant site, and position of the implant. So normally single implant cases are very convenient, but what we in a long-term practice, we get long span bridges, and the patient, because the patient has been wearing the bridge for a long time, all they want is removal of the bridge and immediately placement of the implant, and they want to restore their function immediately because for them it should be as faster as a bridge because they're not exposed to implant practice. And the other cases, like in the second X-ray, the patient have had missing teeth for a long time, but once we plan for implant, they want immediate rehabilitation, posteriorly for the function, anteriorly for the row. This is another case where the patient is the last X-ray. The patient is around 35-year-old, and patient was wearing a long span bridge. If you see, this bridge is a continuous bridge, and there is complete bone loss. When we took IOPAs, there was hardly any bone in the anterior teeth, and we had to remove the entire bridge. Patient wanted immediate implant, immediate loading because patient had to go away to outside India. So once we have determined the number, size, shape, surface, and the thread of the implant. We know type 3 will come to this later on. Some few basic things before I start for the immediate implants. These are between two implants, there should be 3 to 4 millimeter gap. And between implant and the root of the adjacent teeth, it should be 1.5 to 2 mm. And from the opposite occlusal area to the tip of the implant, it should be 7 mm. This is the basic root protocols we should follow. Implant to tooth should be 1.5 to 2, implant to implant 3.4 or 3 to 4 mm. Buccolingual from the cervical height of contour should be 2 to 3 mm. Coronoapical should be 2.5 to 3 mm. And interocclusal or interarch distance from the shoulder of the implant should be 7 mm. The buffer zone should be 2 to 3 mm. It's always better to be in a safer distance than to exactly follow the distance what we have mentioned. What are the orofacial dimensions? So anteriorly, the implant shoulder should be 1 mm palatal to the point of emergence of the adjacent teeth. and 1.5 of thickness of the bone should be present so that the emergence profile should be good. Posteriorly, 1.5 mm buccally and palatally. We know that the implant should be surrounded by good vital bone, buccally, palatally, and in a gap with adjacent teeth. Coronoapical dimension, 3 mm apical to the emergence and 1 mm apical to CEJ of the adjacent teeth. But what are the protocols for the immediate implants? Those were the protocols which we follow for the conventional implants. When we place immediate implants, the bone should have thick biotype. It should have, extract the teeth. It should be minimally atraumatic because we do not want the socket to be damaged so that the osseointegration should be fast. There should be at least 3 walls. 4 wall is the best place to place the implant. Implant margin should be 2 to 3 mm apically. Primary stability is the basic of immediate implant placement. We know whenever you place the implant, first there is primary stability followed by secondary stability. So primary stability is basic for the immediate implant placement and loading. And for that, 3 mm apical bone anchorage is the must. Slight palatal or lingual placement and gap closure by graft. So these are the selection criteria, G233 bone. Quantity, I'm dealing with full mouth, all on 6 cases here. And tapered implants are better. Surgical technique, this is a gist. 1 mm to 2 mm subcrestally, undersizing. Why undersizing? Because the anchorage to adjacent bone will be better and bone condensation. Need, we know because shorter treatment plan, multiple appointments are avoided. It determines the ideal position. We are actually positioning the implant to this natural socket, how the original tooth was there. Better soft tissue aesthetics because we know after extraction there are changes in soft tissue and migration of the teeth into edentular spaces are avoided. That acts as a natural space maintainer. So it's not fair that if we can give immediate implants, it's always better to shorten the time duration, give a faster, easier, and early smile to the patient. So why late when it can be done immediately? Immediacy, these are the classifications, short classification. I'm saying immediate you extract and directly place in the socket. Delayed immediate is 4 to 6 weeks where the mature soft tissue bone is formed and partial bone healing occurs from 12 weeks to 16 weeks. We know healing process, woven bone formation occurs. And then delayed placement is the conventional placement. That's 3 months after the implant extraction, after the teeth extraction. So as we had already discussed, the positioning of the implant, the CBCT will give us a guidelines so that there is a 1.4, in this case, 1.4 mm with buccally, 1.9 mm palatally, to give us a better aesthetics and better emergence profile. In multi-rooted tooth, it is very convenient if they are buccal and lingual, if there is mesial and distal socket, you choose the socket which is better and then place the implant. What is gingival zenith? Zenith is like when we talk, it's almost like a zenith. I would say extra gingival area, which when after healing it after healing it gives a good margin to the implants. Buccal bone zenith is again, we know when we place the conventional implants there is subcrestal bone loss, so we should always place the immediate implants 1 mm below the crestal area so that once later on when there is bone loss, it comes to a they should not get immersed in the oral cavity. Posteriorly also 0.4 to 1 mm vertically inside, and this is the dimensions of the X-rays what they have shown. I'll skip this. Now, once we place the implant in proper position, buccolingual, mesodistal, and inside the socket, so we get this position where the implant is subcrestally, and the positioning of the implant is right on the ridge emerging from the center of the ridge, so that when we place the prosthesis, it is it's on the ridge and up according to the occlusion of the patient. So when we extract, it should be better flapless, proper luxation should be there, minimum guttering because bone loss will be there, copious irrigation, antiseptic rinsing, and laser debridement is suggested. It cannot be done also. So, but in infected socket, we need to do the curettage. That's needed. There is always a question, why when you irrigate, betadine should be used or should not be used. A lot of literature does say you should not use betadine for irrigation. You can use you can use non-alcoholic chlorhexidine solutions for it. So this is what we start with the surgical protocols for the placement of the immediate implants. We place incision on the crestal area. It can be one-sided, it can be two-sided, three-sided flaps, or it can be flapless. So two-sided flap, in case, normally a single one incision is sufficient, because more we retract the tissue, the more are the chances of bone loss. This we have known it for a longer time. Two-sided flaps are done in case of bone grafting or bone augmentation is needed. Three-sided flap, again, in case of staged bone augmentation. And flapless is very technique sensitive. Anteriors, we should avoid it. Posteriors, for beginners, it can be done. There should be sufficient amount of keratinized tissue around the implants when we finally place or reposition the flap. So if we see, this is a simple technique. If there is a posterior edentulous area, we can go on the crest and place the incision. Full mouth, all the more convenient. And then after we reflect, we determine the width of the bone and go further. So why flap reflection is important? Because if we have reflected the flap properly and then we place the implants, we get a proper visualization. There is unnecessary reflection of flap tissue, periodontal tissue is not done, and the placement is proper, and final prosthesis is in the right position. Flapless, it is done when there is adequate bone thickness and keratinized soft tissue. Extensive mobilization is avoided. Small flaps are better because bone and soft tissue healing is better. But disadvantages, we have a limited surgical site. In that, fenestration and concavities might occur. And in case of simultaneous bone augmentation, in that case, flapless is not indicated as a practical thing. So bone healing, we know. Whenever once we place the implants, the primary stability is because of the mechanical friction, the density of the bone, and sequential bone drilling. And then we measure it with the ISQ level, that is the resonance frequency analysis. All of us know that once we've determined the vertical position of implant, the drilling speed is 1200 to 1500 RPM. And the average is 1800 RPM. Initial stability, as we had mentioned, 3 mm apically to the extraction side and 3 mm of the crestal bone on the inside. Torque is 35 Newton. It can vary up to 35 to 70 Newton, should not cross beyond 80 Newton because that will lead to microfractures and we might lose the implants. Secondary stability, it's because of the osseointegration. That's we know it is because of the implant surface, implant and bone surface interface, which leads to osseointegration. Bone density, blood supply. Excessive dense bone also, because of the lack of the blood supply, the osseointegration fails and we lose the implant. Once we place the implant, we measure the torque value, we take the radiograph, check the ISQ value, and go for the prosthesis. So drilling guidelines or the protocols, we know it's 1200 to 1500. We should avoid the pumping movement. Once we place the implant, as I mentioned earlier, 50 to 90, it's better to have 30 to 70 there are different studies suggesting their own Newton values. This is the range. There is another recent method where the drilling should be very, very slow. If you drill the drill implant very slowly, the bone very slowly, the bone does come out. So at a speed of 20 to 30 and with irrigation, and collect the bone which has come out from after the drilling, that can be used as autogenous bone graft, because when you drill in high speed, we lose most of the bone chips which come out, or the bone dust which come out from the drilling socket. Just to mention, the mean torque value is 53.1 Newton centimeter. ISQ value for the mandible is 77 and maxilla. This is an average value which says our implant is fine. Once, as I mentioned earlier, subcrestal bone placement of the implant is very much needed in immediate implant placement because of the bone loss. Any implant system we follow, we go for the sequential drilling and then place the implant subcrestally. And later on, when we do the hand ratcheting, it condenses the surrounding bone. We'll come to denser burrs also, but normally when you ratchet it properly, there is thick bone formation around the threads of the implant, which helps in primary stability of the implants. All the implant systems have different drill systems we follow. We have a pilot drill, then coming to sequential drill pattern and placement of the implant. Concept of active and passive threads. So it is again, there are different eras. Maybe the seniors who are doing implants, what I understand, they say initially there were a lot of propagation of active implants because of the primary stability. Then came a phase of passive implants because they say it has better osseointegration. And now the implant systems, when they come up, they say our implant has both active and passive threads. So that will help you give primary stability and secondary stability post osseointegration. So the basic point should be that initial bone contact should be high, and there should be, in case of primary stability, the thread should penetrate laterally along the bone so that it holds. When we load the implant, it should withstand the mild occlusal forces and it should not fail. I'm starting with the cases. We'll start with single tooth implants. So it's a very simple case. Root canal treated tooth. Patient had not placed the crown. Adjacent tooth also got damaged. So we saved the root canal treated tooth and extracted the premolar. Now, because the premolar was extracted, we have, that's already a surgical guide for us. We prepare the walls and place the implant. And when we place the implant, we have to be very, very sure that we are placing it subcrestally, because we will encounter bone loss here after 2 to 3 months. So denser burrs are the bone. When you do immediate extraction, it's always advised to go for denser burrs, because this will condense the surrounding bone and prepare an ideal positioning for the placement of the implant if you're planning to place the implant immediately. And we get a good torque value after you've used a denser burr. Torque value, we know if we get a good torque value of 30 to 50 after immediate placement of implant, it will suffice our need for loading also. So the mean torque value, again, this is a repetition, 53.5 Newton centimeter. In case there is a gap, supposedly we placed a tooth, we've extracted first molar. We have a buccal and the lingual, we have a mesial and a distal socket of the tooth. So once we placed and prepared the distal or the mesial socket, we can graft the adjacent area so that the support is stronger, and then we can close the flap. Autogenous graft or alloplastic graft. This is a different topic. We'll not go for it. This is an example of a case where patient is highly, patient is very, very conscious about her aesthetics, because when they come to you, all they want is remove my tooth, put the implant, and I want the crown. Because implant placement is not their work, it's our work. All they want a smiling teeth. When they smile, all their teeth should be visible. So previously, we had placed an implant after extraction of the central incisor, and immediate loading of this implant was done within 7 days. But later on, there was huge bone loss, and there are root canal failures and complication in the adjacent teeth. So in such cases, again, the patient came with a similar expectation of immediate extraction and immediate implant placement. In this case, we reflected the flap properly, and we found a huge bone loss here in the previously implant placed, which was, I think, placed 4 or 5 years back. We reflected the area and did a thorough curettage, extracted the adjacent teeth. Again, because there is hardly any bone, the extraction should be atraumatic. This is the socket. We see we get the socket, and there is hardly any buccal bone left. So we have to do the grafting for this. And once we placed the implant, we got a fine torque of around 30 Newton. We placed the graft with the membrane and left it. So such cases where you find the bone defect is 2-walled or 3-walled, bone grafting is of utmost importance, because it will not sustain. You have to support it. And such cases, it's difficult to do immediate loading. We can take a chance for this, but we tried doing immediate loading, but then the tissue was not healthy. So we had to delay the loading of the implants. This is another case where we had done the extraction. This is post-op OPG. Extraction was done, and there is buccal, there is hardly any bone buccally. The bone was very thin. So we engaged the apex through the implant, and there was a bone defect, which was covered by bone graft and placement of the membrane, which was sutured, and we can see the final position. These are the cases where implants were placed immediately, but the loading had to be delayed because of the soft tissue, because the soft tissue was not apt for immediate implant, the loading of the implant or the placement of the prosthesis. So again, this is another case, as I mentioned, a single tooth extraction. We place the implant immediately, but we can see there is a huge gap between the implant and the adjacent bone. So that is called the jumping distance. The jumping distance could be because of the anatomy, could be because of the because of the wider tooth which was existing, and in that case, it will lead to bone resorption, bone defect will form, and instability of the implant. Such cases, again, as I mentioned earlier, grafting is needed. This is a simple, very simple case. Such cases, because even if it is peripically infected, we can easily place the implant because we have a good distance of bone, a length of bone from the crestal area to the margin of the upper margin of the canal. Here again, we done the CBCT, and in this case, it went a bit deeper, but luckily there was no damage to the nerve. The 2 implants placement, this was also, you can see the crestal margins immediately after the implant placement. This implant did not sustain. I'll come to it on the failure parts. There are such cases of full mouth rehabilitation where there are multiple small root pieces, At times, these become the surgical guideline, as I mentioned earlier, and CBCT will help us to place the ideal position. Sometimes it's like if you zoom and see this socket, we try to place the implant in 4-3 position, but we couldn't place because once we extracted the teeth, the socket had become so loose and the grip was not good. So we had to remove the implant and place another implant in the premolar position, taking the liberty of later on forming a big long span bridge anteriorly, but the upper placement were fine and we further planned for the prosthesis. So now we are categorizing the cases as immediate placement, immediate loading, immediate placement, delayed loading, and immediate placement, provisionalization. So we've divided the cases accordingly. So the first, we start with the cases of immediate placement and immediate loading. The key condition for immediate loading is there should be primary stability, torque, as we mentioned, 30 to 40 Newton, and resonance value should be more than, the ISQ value should be more than 65. So what is the classification of loading? If we load it within a week, that's immediate loading. Early loading is 2 to 3 weeks. Conventional loading is 3 months. Another thing is occlusal and non-occlusal loading, where you do not subject the implant and the processes to the hard occlusal grinding, where there are chances of failure, where the primary stability is there but not strong enough. This is a posterior teeth in which the teeth was loaded immediately. This is post-op X-ray. This is 4-7. Why we loaded it immediately? Because the occlusal forces are divided equally all around and the chances of failure is less, acceptance is high. This is another case. We place immediately after extraction and then we plan the processes. Cases like anterior teeth, where we place 2 anterior bridge on the implant. We place a bridge on anterior implants. Again, it is not being subjected to load, but the patient is very keen on the appearance. He wants the prosthesis very soon. Either we can place a permanent or a temporary prosthesis. This is a case which we had shown earlier. This is a long span bridge in the lower arch. And if you see the IOPAs, there is complete bone loss at the root area. So we did single sitting extraction. There is hardly any bone support here. And then we place the implants. I do not have the post-op X-ray OPG of the patient. Patient was in a hurry. And then we place the provisional prosthesis. Patient is wearing the prosthesis and is able to chew onto it for last 1 year. Patient has called again. The patient is outstation. Patient is called again after 1 year for the changing of the prosthesis, because later on it will lead to tissue changes. So if not loading, we can do early provisionalization of the implant, because aesthetic is of prime importance. So this case again is a 35-year-old young man with aggressive periodontitis. We do not have any bone support. All the teeth were grade 3 mobile. Patient did not have any medical condition. It was because of the ignorance and poor oral hygiene maintenance. The patient had lost most of it. In this case, we did single sitting complete extraction of the teeth and placement of the implant. So if we see, out of all these implants placed in the position of, if we see in the second quadrant, in the position of 2-4, we've lost the implant here in 2-4 because we placed the implant in relation to aggressive periodontal condition in this teeth. We made a provision for the patient because, with acrylic, so that patient, the implants had good torque value, the stability was good. We made a provision for the patient so that the patient should get used to the height, the occlusal pattern, the soft tissue should get used to the biting pattern. And then we, after 3 to 4 months, we made a final prosthesis for the patient. This is again, patient, especially young male or females, they have long-standing bridges. This patient had periapical infection. She's a very old patient of ours, multiple periapical infections in the anterior area. We had treated it surgically. Patient was fine for 10 years, but again, she came with periapical infection in laterals. So we did an extra removal of the bridge, placed the implants on the lateral sockets, and then we gave her provisions. This is another case of provisional prosthesis given to this the patient. The patient is around 60-year-old patient, and she had a long bridge. Laterals were damaged. We removed the bridge. We did got the endodontist to treat the canines, place the implants in lateral incisor because we have a good amount of bone in the lateral incisor. It's more like a delayed implant placement because we have healthy bone there, and we gave a provisional prosthesis on the implants so that the patient should not suffer any aesthetic problem. This again has multiple root stumps, missing teeth. So it is a kind of full mouth rehabilitation case, and we placed the implants. Their position was not ideal, and we gave them a provisional prosthesis. The advantage with this is the tissue form of the teeth, especially in anteriors, it is maintained. It gives a better aesthetics. This case can undergo a discussion because there are a bit of loopholes, but yes, to utilize the anterior gums, we placed the implants and then we found we loaded the implants. This case is a case of canine impaction and cystic changes was there in the first quadrant, that is 1-3. We removed the canine. We did not have good amount of bone. Placed the implants laterally, waited for 3 months for the bone graft and the implants to settle down, and then we did the processes. So this is a case of immediate extraction, immediate implant, and delayed loading of the implants. So the problem with placement of implant, loading of the implant after 3 months or in a long edentulous case, patient has to get used to the new bite form, the cheeks, the tongue, and even the phonetics. The training for the phonetics also has to be given for the patient because patient finds it very odd. Patient finds the teeth is proclined and the phonetics is altered. This is case, we'll start with the prosthetic point because we have 15 minutes. This is the placement of implant, ideal placement. We know once the implant is placed, we place the healing cap once the tissue is formed, and then we place the abutment and the processes is started. A small discussion on platform switch versus platform matching implant. Platform switch implant is, both are good, but yes, studies have shown that in such cases, platform switch implant pattern and prosthesis is better because it reduces the chances of peri-implantitis, reduces the crestal bone resorption, and better tissue sculpturing to meet the aesthetic demands. Abutment seal is important, reduces the macro leakage, maximum clamping forces should be there, and once it is the implant and the abutment are fixed properly, there should be maximum stability of the implant so that it can withstand the occlusal forces. Prosthetic concerns, I'll just read it out. Scalping of the periodontium, crestal bone level placement, smile line, morphology of the gingival tissue, proposed inter-implant distance, existing occlusal contact relationship, and interproximal bone level. So this we know that what ways we have found or we've been doing for the prosthesis is healing cap. We see a good collar of tissue being formed here. We take open tray technique or closed tray technique impression and send it to the lab for the prosthesis. But with the use of scanners, it's I've not put the video. You can use, it's very, very simple. Once you have placed the implant, put the scan bodies, send it to the lab, mention the size, and if you want, you can do a jig trial and do the prosthesis. This case, it's not an ideal way for the prosthesis, but the patient was could not come for the multiple implant visits. So we placed the implant and left it for 3 months, and then placed the abutments and directly sent it to the lab after scanning. And there was a provisional prosthesis, which was followed by a final prosthesis. The complication is lack of primary stability, which I had mentioned earlier, a couple of teeth which has less bone anchorage or periapical infection. In such cases, we do not have primary stability. We might have to remove the implants during the procedure or intraoperatively. And post-operatively, there can be infection, lack of osseointegration. So what points are there to ponder is case selection for immediate implant, primary stability, progressive loading. That is very important. If you place the implant or told the patient that will be loading it immediately, it is not a right thing to do. You tell the patient, we place the implant and we'll load it progressively and see how it's resulting, and then we'll give the final prosthesis. Immediate loading when indicated. So the complications, what we can encounter in cases of implant placed immediately, like this patient, we were planning all on 6 in the lower arch. There are 2 implants to be studied. So one on the right side, the 4th quadrant. When we remove I've just put 2 X-rays just to show that if we place the implant in a healthier bone, it's easier and it gives a better result. The prognosis is better. In the left side, there is a huge periapical radiolucency. I took a chance, curated, did a good curettage, irrigation, put a very good bone graft, but ultimately we lost this implant because the huge defect did not let it have the primary stability. So we have to choose the position well and the case well before placing the immediate implant. This is another case where the patient had his severe bone loss. I placed multiple implants and I lost my centrals. I was thinking of placing all on 4, didn't go well. Then I tried placing anteriors. I lost the implants, and finally, I placed it, but then we are planning for zygoma or after a rescan, a better prosthesis for him. There are complications in posterior immediate implant placement. We find the torque is good and we load the implant. This is a bridge which I had placed, and within 6 months started showing peri-implantitis, and we had to remove this implant because it could not withstand the load. So progressive loading is important. This trauma cases, there are a lot of trauma cases for us as maxillofacial surgeons, especially anteriors. Posteriors, they wait for some time, but anteriors, they want their implant placed immediately. And patients, as we know, are educated. They come, they do not want the bridge. They don't want the adjacent teeth to be cut. They want implants immediately and prosthesis immediately. This is a case where the patient had missing teeth here, and patient had a previous trauma. We placed the implant. It isn't overlapping. There was a gap between the implant and the tooth. We lost this, the 4th quadrant implant. And then we had periapical infection in the lateral incisor. We did a root canal. We again lost the implant. And then the patient is ultimately with a single implant. We didn't have an option. We placed the graft we gave him a bridge and we are waiting for 3 months. So aggressive planning is not right for implant placement immediately. So we need to respect the limits and follow the protocols. This is another case. I a failed implant. This patient had come for full mouth extraction, full mouth implant. I lost multiple implants into it in this patient because of lack of primary stability, periapical infection, and I couldn't give the patient what she was promised. Then there is another problem with the tissue changes. Once you place the implant, immediately load it. Late after 3 months or 6 months, there are tissue changes. Patient might come after 6 months to 1 year with lot of food lodgement between the prosthesis and the implant. In that case, we remove the prosthesis, clean the area, and change the prosthesis. I would like to end the session here. Thank you so much. And as Sir said, implant is joint teamwork. So it cannot be done with without a good radiologist, without a good prosthodontist, and without a good endodontist, who helps us to rehabilitate our adjacent infected teeth. Thank you, sir. Thank you for your patient listening.
Thank you very much, Dr. Richa. Actually, it was nicely, you have covered most of the areas also in this short time. Actually,
So I think I skipped. I thinking the time shortage. I skipped a couple of slides. I could have covered it, but I was not sure. I thought I was going too slow.
Right. No. Test all areas, even the very crisp way. You test all areas. Critical areas were tested nicely. Good.
Thank you, sir. Anything?
Right. Yeah, more a lot of clinical cases also you showed, and so definitely will be beneficial for the participants.
And I think, sir, just because we have we have time with us. Immediate implant placement is not a big thing, so it's made a huge hype. You place the implants immediately. Most of the time when we have immediate implant, either they are periodontally damaged, we have a good amount of bone below the periapical infection or the infected part of the gums. So once we do a proper curettage of the area, we get healthy bone for the anchorage. And I do advocate scanning, sir. Scanning has solved, I would say, half the work for oral surgeons like us, because we have less idea of the prosthesis parts. Like with the CPCT, we know where to place. We have a clinical experience also, but scanning, it helps us to plan the implant. The processing work has really gone down. Just put the scan body, scan it, send to the lab, do a trial, and then the processes comes to you. So people who are doing implants should also start using scanners for the pre-implant analysis of the patient, which will give us a better idea of the aesthetics also. And processes, yes, sir. It is very simple. Earlier, we used to trim the trays, take the open tray technique, closed tray technique, and half the time we had to repeat the impression. The patient used to be irritated because most of them are like either elderly or they had to come again and again. So I think we should advance our clinical practice. Most of the practitioners are using scanners, but scanners for implant is definitely a boon, sir.
Definitely. Now the lab people, they come with the scanner and take it.
Yes, sir.
We don't have to invest on scanners nowadays.
True, sir. But it's been even in Jamshedpur and Bhagalpur for last 5-6 years. And if you have your own scanners, that's all the more good. Otherwise, that's also, I think all the good labs have their scanners. All.
Correct. And if you scan it out, means you have good occlusion, good precision, everything. For us,
So,
especially as you said, Our prosthetic skill may be minimal, so that part will be beautifully taken care by this if they scan and do the crowns.
Yes, sir. Yes, sir. I don't think, sir. I've covered most of it, sir. Few things I didn't go and elaborate because that itself would
Yeah,
take.
that is impossible. Yeah, we know that. Right.
So,
Sir, there are 1 or 2 questions in the chat box.
yes,
Yeah.
sir. I just
Ma'am.
8 minutes. Sir. One moment, sir. I'm not able to find the chat.
We'll read it out for you, ma'am. No problem.
Yes,
Sir, you will read or shall I read it out?
Yeah. Dr. Akhilesh.
Okay, I'll do it. Sir.
yes, sir. There
Ma'am,
is one question. In relationship
Is-
of implant length and immediate loading, is there any relationship of implant length and immediate loading? Is it possible short implants loading immediately? More than the length, as we know, the diameter of the implants are important. So if you have a good diameter, and I would repeat, if your primary stability is good, the torque value is good, you can load the implant and you can easily load the implant. But then depends if it is a single implant or multiple implant. Like I'd shown in my case, if there is a single implant, posterior implant, so we loaded it because the occlusal forces are equally divided. So do not subject it to high occlusal forces. And if the diameter is good, you can definitely load the implant. Good evening. Are basal implants superior than conventional implants in terms of immediate loading? Yes, the people who are using basal implants, they do say that basal implants can be easily loaded. There are different scientific approaches. They are different. It has a different anchoring process. The conventional implants has a different anchoring process. I don't think there is comparison. You can load it equally.
See, I have a little input I can give with my experience.
Yes, sir. Please do, sir. I have not used basal implant much, so please do it, sir.
I do both. And
Yes,
it is probably this may not be a good platform to discuss on basal implant because it's a totally different ball game and a different science.
Yes,
so
true.
better we'll avoid that. So in these conventional implants, actually the crown root ratio better to be considered. So somebody asked about the short implants. So probably short means you have a lot of loss of the crustal bone. That means the crown on top is going to be a big one.
Yes.
Usually the ridge resorption is more, means your occlusal planes remains the same, especially in 1 or 2 implants, not in full mouth. In sectional implants, your crown root ratio is going to matter. Now you are going to keep a big crown on top of a small implant. So their initial stability alone may not be a major criteria. Now in active implants, you will get initial stability. It is because of the design of the implant. Doesn't mean that the bone is excellent or good or something. It is once you have a larger thread that is designed by the manufacturer, you will get good stability because you have under-drilled threads are very wide, larger than the core diameter.
Yes.
So you get good initial stability and give a pseudo confidence also. So you should consider all these aspects. What is a load? What is a site? Not stability alone. Initial stability, just two threads catches nicely also give you in good stability.
And that's what's a progressive loading. I showed my cases also. I got a good initial stability. And then after 6 months, the patient comes with a loosened implant and the processes. So it's disheartening for the patient and the implantologist also.
Right.
So there's a last question. Suppose the patient complains of paresthesia in immediate post-operative period. So mild paresthesia can be there because of the pressure, but then inferior alveolar nerve drilling will not be possible if you follow the protocols. You determine the CPCT positioning of the implant. Only one case, in case of second premolar, where there will be looping of the nerve. In that case, you should avoid placing the implant very close to the canal. You should give a gap of 2 to 3 mm distal to the mental foramen. in that case, you will avoid drilling to infraalveolar nerve. I don't think if you plan well, you will drill into it. Is that fine, sir? You would like to add something?
Yeah, if in paresthesia and this question, if it is paresthesia, you observe in the next day or later, you have
Yes, sir.
fixed the implant and you have observed paresthesia, of course, to take the radiograph and make sure it is not in the canal.
Yes, sir.
If the radiograph shows that you are in the canal, definitely you have to remove the implant. So
Yeah, that's true, sir. Huh?
if it is if you have a good clearance from the nerve, but still paresthesia, definitely you can wait and watch. Probably some injury might have happened during the drilling period, but that usually repair if it is implant is not pushing into the canal. So drilling injury, it is not a permanent reason for a paresthesia. Usually it repair because the canal is almost patent there. So it will repair. It might take time, but it's every chance for repair. And you can't do anything also if you don't repair.
But I think drilling injury is very common, sir. Even we suddenly, we put a bit of pressure while drilling because there are, if it is dense and suddenly there is a dip. So it does happen with us also.
Yeah. So that is not a big problem. But if you're pushing implant also into the canal and so that the injured part of the nerves are separated permanently, absolutely no chance for repair there. So if you see in the radiograph also in the canal, the implant in the canal, 100% retrieve the thing and wait and go for a shorter implant or wait for some time and then redo the implant later. So rather than waiting and telling the patient it will repair by itself, it will never going to repair. So that should be strictly radiograph, definitely a good tool. Even after pilot drill in close proximity to the nerve, you check with your pilot drill or 2 mm drill, twist drill, then confirm your depth and then proceed with the larger drills. See, even 2 mm drill perforating the canal may not be a permanent injury. So with 2 mm drill, at least you verify with your radiograph, especially if you are in close to where you have a very short mandible, confirm and then proceed. So that will be then liberally we can check the depth and place your implant.
Yes, I think the protocol should be set the moment you place the implant. Radiographic confirmation is it should be there for after every implant placement.
Correct. So the questions are.
There is one more question, sir, from Shankar sir. Will undoing few turns help? Will undoing a few turns of the implant will help in relieving the? I think that is the question.
Yes, sir, it can help, but then if it is not placed, if you exactly measure the length, the threads will be intraorally you can see the threads then. But
then go for a shorter implant. Remove the implant and go for a shorter.
Change the implant. That's better because that will lead to prosthetic complication later on. But if was the question if there is it has happened with me also a couple of times. I've placed it deeper and then we reverse turn and then left it. So would you like to say what will happen in that case? Mostly there is bone formation below the implant. Wherever you have reverse threaded it or removed the implant bit, like you have twisted the implant, there is bone formation.
In terms of nerve injury, that is a good idea. Take it to few threads up. But what is the fate of the implant? As you said, the threads will be then in the mouth.
Yes.
So that doesn't work. So you make it short of the nerve, that's sure, no doubt. It should not impinge into the canal. Then better is just remove it, go for a shorter implant. If you have gone with a 13 mm, go for 11.5 then. But crustal thing, it should be equicrustal or little bit subcrustal. That is no doubt in it. So removing few threads down may not be possible. Yeah,
plus you're not confident and it gives you a sleepless night also if there are multiple implants like that, sir. Plus, I think, sir, we should have a good inventory also. When you're planning multiple implants and you're doing immediate implants, you should keep extra inventory so that your work should not come to standstill because of such problems. That is
Right.
very much needed, sir.
Depth guides are also there now with some implants. So you can use the guide so that whatever you press means it won't go beneath that depth.
Yes, so different systems like some are length specific drills, some are not
Yeah.
length specific drills, but for beginners, you can go for length specific drills so that the chances of over drilling or puncturing into the nerve is lesser.
Right, right. Implantology, the simplest thing is there is no shortcut, just do and experience the failures and correct it yourself and proceed. That is the only thing, trick in learning implantology. Don't get scared about implants and failures. Don't give false promises that you will definitely load everything immediately. No,
Yes,
nobody
sir.
in the world can do that in all
True,
cases.
sir.
So that is all. And if the patient wants immediate loading, that everybody in the world like to have immediate loading, but that is not possible. So don't give false promise that I am an immediate loader. Every
No,
case-
yes. But when the patient comes, you have to make sure and tell the patient that I'm placing the implants. Let's see how your bone reacts. That's the best way to talk to the patient. And my first implant, what I placed, I still played to Lord Hanuman. Till date, I play to Lord Hanuman. Please keep my implants holding in the bone. So that's it.
So that is you cannot give such promise at all. You try for that definitely for immediate loading also, but no, definitely you cannot guarantee before doing it this that you will load it immediately in 100% situations. Of course, may be able to do, but not necessarily, because in extracting the tooth itself, there's little bit of cortical plate extra fracture of means it's a problem. Now we use periotomes also.
Yes, sir.
With piezo-headed periotomes we use for extraction. So that will prevent then what we call root shielding techniques. A little
Yes,
bit
sir.
root remains there. So that also some people follow that. I'm not a fan of this kind of thing, but still so many people do that technique for to preserve the labial wall in immediate loading situations.
So one segment which I couldn't include much, there's a whole cases of trauma patient and immediate loading, because we get, as oral surgeons, we get a lot of trauma patient, and then after, like, they want immediate implant placement. The prognosis is very tricky in trauma patients. Initially, we get a good anchorage, and after 3 months, suddenly there is complete loss of bone support. So,
Right, right.
so such cases, especially anterior bone loss, or if the patient has fallen down directly facing traumatizing the labial cortex, and
labial will be weak.
yes, you should be careful in choosing such cases.
Correct, correct. Now CBCT or even CT also will tell you better rather than previous situations we do with OPG alone. Then we, after opening up only, we see the reality. Now that is little easier now with CBCT. At least you know where it is lacking and where it is adequate. You can little more predictably inform your patient earlier now.
Yes, sir.
Yeah, I think enough time.
Yes, sir. I think we can. I think there are no more questions in the chat box, and we can wind up. I think I request Dr. Anand Shair, Joint Secretary, AOMSIKerala, to give the vote of thanks.
Hello. Good evening, ma'am. Good evening, sir.
Good evening, Dr.
I was listening to the entire talk. It was so much loaded with information, both a bit of theory and more of practical, I suppose. It was indeed very helpful, ma'am. And sir, it was very nicely, the last session especially, it was very well coordinated by you. And ma'am, you had covered everything, which is very important, even for a beginner who is going to start practicing implantology. Thank you, ma'am. Thank you so much. And sir, thanks to you too.
Doctor. Thank you, Dr.
And I thank the entire audience. At certain point, we had even nearly 150 participants at certain points. So,
Thank you.
I thank ma'am, sir, and Akhilesh Pratap, sir, our vice president who was here, and all the senior faculty who have joined us, PGs, everyone who was there in the there as participants. Thank you all. And here we can end the session.
Thank you.
Thank you so much. Thank you, Dr. Akhilesh.
Thank you, Dr.
Mathew.
Richa. Thank you, Dr. Mathew.
Thank you, AOMSIKerala chapter, for giving me this opportunity. Thank you so much.
It is indeed a great pleasure for us, ma'am. Thank you.
Thank you, sir.
Thank you.
Very
Thank you.
much.
Good night.
Right.
Good night, all.
Good night. Good night.